Here we go. Great. Okay. Hi, everybody. Thank you so much for joining us today. My name is Ed Hurwitz. I am one of the co-directors of the Learning Health Systems Collaboratory at Michigan Medicine. I also have a title of the Learning Health System Clinical Champion. It's my pleasure today to welcome you all to this session. Note that today's session is being recorded and will be available on our collaboratory website. Next. So this is our 2024-2025 LHS Collaboratory Seminar Series, and today's talk is going to be on the Cerebral Palsy Research Network. I'm very excited to have this talk. I've been working with the Cerebral Palsy Research Network for the past 10 years or so. Next slide, please. And our speaker today is Paul Gross, who's the founder and CEO of the network. Let me tell you a little bit more about Paul. Paul founded the Cerebral Palsy Research Network, and as I mentioned, he's the president and the CEO. He's the driving force in accelerating clinical and translational research in neuroscience for cerebral palsy and for hydrocephalus. He's also the co-founder of the Hydrocephalus Clinical Network and a co-founder of the Adult Hydrocephalus Clinical Research Network. In his role as vice chair of the HA Research Committee, he's played a leadership role in creation of the Hydrocephalus Association Network of Discovery Sciences, a virtual laboratory to accelerate basic science advancement through the collaboration of neuroscientists and hydrocephalus. In 2015, Paul was given the Making a Difference Award by the American Academy of Cerebral Palsy and Developmental Medicine. He recently completed a term as advisor to the National Institute of Neurologic Disorders and Stroke. Prior to ramping up his focus on medical research, he was CEO of a web startup and a senior vice president with the Microsoft Corporation and with Borland International. In personal life, he's married, the father of 2 children, one of whom has hydrocephalus and cerebral palsy, and he's also an avid mountain biker. Paul, it's such a pleasure to have you today. Paul and I have worked, as I mentioned, worked closely for many years, and he has some very exciting work to share with us. So, Paul, please go right ahead.
Great. Let me just grab my slides. I think I hear myself echoing. Okay. All right. Are my slides up?
Yeah, they look great.
Great. Well, thank you so much for that introduction, Dr. Hurwitz. So I'm going to talk to you about the Cerebral Palsy Research Network and where we've managed to get to in 10 years as a learning health network. And so this is a photo of a good number of us gathered in Delaware in 2023 for our annual meeting. So I want to give you a little bit of the background of how this got started. In late 2014, there was a NIH workshop entitled The State of the Science and Treatment in CP. And this workshop was very different than any other one I had been to. At the end, the organizers stood up and they said, we heard these 6 themes and they assigned them to attendees and invitees to the meeting. The first was the need for a national registry to track improvement in outcomes. You know, if surveillance could be done, that'd be great, hard for our health system. The second was the need for more comparative effectiveness research to compare the many interventions that are available to people with CP. The graphic here is from Dr. Iona Novak's traffic lights paper that she did in 2013 and then revised in 2020 that shows all the different interventions and the level of evidence and effectiveness of those. And so there's a really strong need to compare those. The third was the study of adults. There's an estimated 1 million people in the United States with CP, and if you just look at a bell curve of age, that means there's roughly 800,000 adults with CP, and at the time there was close to 0 study of adults with CP in the United States. There was a need to develop an agenda for basic and translational research. You know, the crew that was at the meeting was all, you know, mid-career to late career, and a real sense that there was a need to bring young investigators into the field. And there were a lot of parents, including myself, that were there, and there was a stated need to create closer connections between patients and families and researchers and clinician investigators. So We were founded in 2015, the next year, with a mission to optimize the lifelong health and wellness of people with CP and their families. And the core focus was high quality research, education, and community programming. And so one of the first things we did was we got together, we ran a 3-month program to set a patient-centered research agenda. It was funded by PCORI, and this is 45 people split almost evenly, as evenly as you can split 45 people between community members and clinician investigators. And we published a paper out of that called Setting a Patient Research Agenda, Patient-Centered Research Agenda for CP. And this is called Research CP, and this really has guided our work and was really a very collaborative effort with the community. So I'm going to take a moment and read our vision because it really speaks to where we are and where we're going. And so our vision is that by engaging a community of stakeholders and a very large number of health systems all together in a learning health network for CP, we can collectively focus the research and the care. So our name has research, but and the care and quality improvement with CP on the health issues that matter most or most pressing to that community, which are participation and quality of life. So we gather and share those lived experience of community members, and we measure aspects of the healthcare process to continuously improve their health and well-being in ways that matter to them. And so this is a very core aspect. And so if I just share some milestones since we were founded in 2015, it's important to note that we are a patient advocacy organization in addition to being a research and quality network. So we've launched a number of materials where our focus is providing evidence-based information in lay-friendly language. And importantly, about 4 years ago, we launched a monthly webinar series where we talk about the work that's going on in the network and we engage the community in discussions about that. From a research and quality perspective, the first thing we did before we did our patient-centered research agenda was that first item from that NIH meeting, which was a task force that I was co-leading. And you can see that our clinical registry now, which was launched in March of 2016, has more than 15,000 patients from clinical visits at our more than 30 centers. We have 35 centers now. We also launched a community registry so that we were gathering information from people in the community, not just when they were in clinic or in the hospital, and that's got nearly 3,000 people. We did our patient-centered research agenda. We went on to get some significant funding from the National Institutes of Health with a genetic causes study, and we partnered with the largest private funder of CPARF. So we started to work to build collaborations within the CP space rather than having these silos of different organizations raising money and funding research. We have 6 active quality improvement initiatives in the network, including things like looking at hip surveillance, which is critical in CP, and then early detection of CP to move the diagnosis age up from an average of 2 years to less than 12 months. And they're very active across the network with multiple centers involved. But we're also very academically focused. We've had 18 publications. We've had 2 more accepted, more than 50 academic presentations. It feels like 50,000 to me, pardon me. And then we've got 7 manuscripts that are under development currently. So at this stage, our registry is tremendous for both publishing off of as well as identifying significant practice variation, which can be key to doing improvement. And then lastly, we are also doing work in wellness where largely we partnered with a National Center for Health, Physical Activity, and Disability to offer a virtual program for health. So I want to focus on how do we get to 15,000 patients. The way we collect data is a core part of who we are. I've got this little pink square here because I'm going to reuse that. So these next series of builds are about this, and then there's going to be a pause and I'm going to come back to it. So we started by taking Epic and working with what was our lead site at the time, is our lead site, Nationwide Children's Hospital. They had these forms built into Epic where the way the clinician interacted with the patient and patient family was by clicking on checkboxes and doing drop downs, with something that then generated their note, where the blue represents the discrete data in their note. We started working with them, and then we created a number of different ways to do similar documentation. So using smart lists within Epic, something innovated at Michigan was the concept of just putting a link into the note that would pop up a small form as opposed to doing the whole note in a form. If you're a note writer shop, we have smart blocks built for note writer to collect our data. If you're a Cerner site, we've got some instructions for how to do similar things in Cerner. And in the future, we hope to be able to capture discrete data from dictated notes or just from textual notes through a combination of machine learning and other tactics. So we do support chart abstraction, and our registry does have roughly half of our sites are doing chart abstraction. The biggest focus of that are sites that are documenting the surgeries for CP using REDCap and a clinical research assistant. But in the end, what this means is we have discrete data about cerebral palsy that is collected as part of usual care in our registry. And the same format is collected at each site. So this is my apples. We collect apples everywhere. And in addition to those CP elements, we get encounters, procedures, conditions, diagnoses, what's being prescribed, death, zip code, all extracted from the EHR. And then that data that's extracted is sent to our data coordinating center. So to give you a sense of just a few data points, here are some snapshots from back of May of last year. We just hit this 15,000 number in the last week, but it didn't jump up by quite 5. But so here's the distribution of gross motor function classification system level. This is a very key data point in cerebral palsy because it's how people with CP move around the community. Do they walk independently? Do they use assistive devices? Are they a wheelchair user? And so you see the distribution of that. And then there's a large missing number because we not only collect data about those that are seen in a CP clinic using those forms that we showed, but if they go into an ortho clinic and they're getting a CP surgery, we're getting that through like a G80 star, the ICD code for CP. And then if you look at another key data point, age, you can see a bit of a bell curve, but that's because most of our institutions are pediatric in nature, but it looks like about 26% of our patients are adults. So we also have a community registry. And what the community registry does is encourages people to join in a portal that's part of our website. And then based on some information they give us about their CP, we present them with meaningful studies that they qualify for. So this is through informed consent, where the other registry is done through a waiver of consent. And then we send them email. We kind of badger them slightly to click on these links or follow this link to do a study. And the studies are all surveys built into REDCap. So just to give you an idea of the difference on these two data points that I just gave you, you see a very different looking curve of GMFCS here and a very different looking sort of balance of age. And where the first set of numbers has a clinical bias, like who seeks treatment and hence comes into the hospital, it is not a surveillance view of the country. This has an internet bias of who's out there advocating for themselves and willing to contribute data. So we see it leans more towards people that are ambulatory and people that are adults out there self-advocating. So this network is 35 centers. The green pins represent sites that are actively collecting data into the network. If they have a green circle, they're a lifespan center. The yellow pins are sites that are still working on our technological implementation. The red pins are sites that are still working on just getting the agreement finalized. And then the blue pins are all the sites that have raised their hand and say they want to join, but there's funding requirements. There are local resources, so not everybody joins immediately after sort of raising their hand. So let me talk a little bit about this as a learning health system growing into a learning health network. So we take these standardized data collections for usual care and we integrate them into the hospital's EHR so that usual care can be done with some structured data. And that allows us to capture data of all these different types. So, all the patient characteristics, all the measures and scales that are applied, if they are getting treatments, either medical or surgical, and what are the outcomes. And it allows us to then store those in the CPRN registry, where what we're working towards is a local registry where all that data is accessible to do things about that cohort of patients at the hospital, but also to centralize it in a national registry. And then as we improve outcomes, we're able to make changes to these forms and templates to actually do implementation and spread of the core outcomes that we create. So the way we then turn this into a learning health network is we gather all this data in a singular data coordinating center. So our sites sign a participation and data use agreement that refers to a set of standard operating procedures that are collectively developed within the network, and they sign that agreement with the CP Research Network. And then on the back end, the CP Research Network has a statement of work with the University of Pittsburgh, with Steve Wisnaski, who heads their co-directs their epidemiology data center. And so that creates a way that our little, nonprofit can actually have this very big collection of very important medical data. So this is the way that we get to a learning health network. We have all of these individual learning health systems working together to combine data and to collaborate. So let me talk a little bit about our research and improvement strategy. In other networks I've been involved, we've tried to sort of raise the money to do lots of pilot studies and whatnot to make studies happen. Here, what we're trying to do is invest in the infrastructure to let 1,000 flowers bloom and really stimulate the ecosystem. So we set the patient-centered research agenda. We build the infrastructure of the registries, the network, and that data coordinating center to help clinicians with the data they need to look at practice variation or to develop studies. We try to balance between generating evidence, so answering unanswered questions, and just assembling teams to improve care and improve outcomes. And then we use that registry and all that data to both support research for hypothesis generation or recruitment planning, and also to monitor the implementation of our improvements and the outcomes over time. So let me ground this in terms of the standard operating procedure for creating a study. So these are stages, this funnel are the stages of teams get together and they generate an idea, and we have a required concept that they produce. And then that gets reviewed, as there's a two-stage review just to get the concept to be approved to either go for funding or to be implemented internally. If it's implemented internally, it can go into execution within a short period of time. If it's external, it goes for funding, and if it gets funded, it then gets implemented and executed. And then, of course, we take the results, we write manuscripts, we seek to get them published, and then we try to take the learning from that and roll that back into that learning health system model. So I'm going to run an animation here. You're going to see a set of ovals appearing with a name of a study or a quality improvement effort. The quality improvement efforts are in green. The other studies will be these ovals in these three different colors, just based on what population they are addressing. And you're going to see a little ticker go across the top for each year since the year we were founded. It takes about 10 to 20 seconds, so I'm just going to let it go. Okay, so not quite 1,000 flowers yet, but a lot of energy and activity, a lot of publications, a lot of ideas working their way through this pipeline and then getting implemented. And I will say that a number of these quality improvement projects have actually produced manuscripts as well. And so I think with each significant smart aim being accomplished, we very often feel like we have valuable data to share as generalized learning with the community more broadly. Uh, so just to highlight some of the examples of those improvements that our registry really helps us implement is, so one of the first things we did was an improvement of the assessment of pain in adults, and we were able to grow that from 24% of the visits to 90% of the visits. Pain was being assessed. And that was one of the top items that was in our patient-centered research agenda. And then we were able to take that data and use it to apply for a grant for a study of pain classification, which is just entering its second year right now. And in addition, we were able to take some of those improvements and push those into the notes that physicians are using to be able to spread that improved assessment, and we'll be able to track that over time. We also improved the diagnosis of dystonia in cerebral palsy from 42% to 60%. This is another ongoing effort. The consistency and knowledge around diagnosis was the top ranked suggestion in our patient-centered research agenda that we did for dystonia, and it was a suggestion made by a patient family. And now, as a result of the work that we've done there, we have a lot of data that's helping us with a dystonia treatment trial, which is currently under development, which was also ranked highly by the community. The core part of the registry is just the implementation of 5 required elements about CP. And what we found is just implementing that is key to implementing something like hip surveillance, which, as I mentioned, is critical to children with CP because of the risk of their hips subluxating or dislocating. And then finally, we've more recently started on this early detection care pathway to do a pilot of doing that as QI as we develop some infrastructure in Epic to make it much easier to manage this fairly complex systems-oriented care pathway, and before we can spread it. So we've got pictured throughout this and involved throughout this members of the community, so partners in co-production for us. I and my co-founder are both parents of children with CP. So at the very, sort of top of the food chain, we are driving this work as community members. So if you take a look at the gray as being all sort of stakeholders, we have this thing called MyCP, which is this portal on our website where we recruit community members, be they physicians, researchers, industry, but mostly members of the community, either parents or adults with CP. And we do these webinars and we see who engages, and then we get those people that engage in our work to be community advisors, and we get them to work with our site investigators on our study teams. And so this has been very effective, but we certainly want to just grow it. So we're investing in some new areas over this year to try to grow the number of stakeholders that are involved in our work and double the size of our community advisors so we can involve them in every study. And at this stage, they're not involved in every study. It may not be a investigator initiated idea. It may be on our community agenda, but they don't all have members of the community deeply involved in them. So we create these opportunities to partner with us. So we have several roles that people can do. They contribute to our community-centered research agendas. They can be advisors, and we have a very active group of people that review every one of our new concepts, and they are invited to join our study teams but we have 10 of them, and as you can see from the diagram I did, a lot of studies. They can be advisors and attend our annual meeting, or they can co-develop a study. And then ultimately, we have had some co-lead a study team, and they can establish a question, that those are key roles. And then we do organic training around research and quality improvement in those study groups. And we really try to help the community members figure out how they can just share their lived experience and how that can be so critical to the processes overall. So what's new this year is we're trying to formalize some of this research so we can point them at things and that we can pay them for their time and not just count on their goodwill as volunteers because it either gives them access or has them feel good about helping advance the field, but actually acknowledge that there's the time that it takes to do these things is valuable, and what they bring to the table is incredibly valuable. So just some examples of what's going on. And as I say at the top here, it's a continuum. It is not one role, but we have 2 adults involved in our pain assessment QI work, and then a whole panel of adults that are involved in the consensus process for the pain classification study. We've got a mom and a teen involved in our dystonia diagnosis team doing that QI work. Our whole adult well-being and chronic pain study, which runs on our website and has gathered some 800 people and we've started to publish off of it. That was all built with a set of advisors from the community that helped help develop the questions on the surveys, review the surveys, give us feedback all the way along. And then that broader circle of really inviting the community into our patient-centered research agendas, or each one of our studies. We present our studies before they're fully formulated to get input from the community, and those are all open to the entire community. I said there are examples where we've been co-leaders. I've been a co-principal investigator on numerous NIH submissions, none of which have been funded, so that may have not been the best idea, but it's still, the team of people are open to the significant role that a member of the community can play. And then my co-founder, Michelle, has been the co-investigator on our study of cerebral visual impairment. So in summary, the benefits of other sites, other hospital systems, other clinicians participating with us, we summarize as these 4 core benefits. There's enhanced knowledge sharing. So one of the things we ran was this models of care session. So we meet as a group twice a month. And so with 35 centers, our meetings twice a month, 1-hour meetings, are typically attended between 30 and 50 people from these different sites. So we ran a series where each site presented their model of care for CP, because it's a multidiscipline approach. It requires some clever things with clinic space and who's involved and timing and scheduling. And so we shared that across 12 of our centers, and we will publish a paper off of that. We've done some academic presentations. So there's great knowledge sharing. There's the improved care quality that comes out of our QI methodology, a really rich collaborative research portfolio, and great opportunities for the academic participants to advance their career. And what I think is unique about what we do is this connection between the EMR and the registry being part of usual care means that we are not predominantly relying on duplicate data of clinical research assistants extracting data. We also have this big set of patient-reported outcome measures that can be linked to all this clinically validated data, which strengthens the sort of perspectives we have from the community and the meaningful impact of the work that we do. The network supports hypothesis generation, identifying practice variation, and the whole infrastructure provides a platform for sustained improvement or sustained research. And in particular, when studies are capped at 5 years when funded by the federal government, this really enables the study of long-term outcomes, and it is key to implementing a learning health network. So there's lots more to tell, but I want to leave lots of time for Q&A. So that is what we've been doing over the last 10 years since our founding in about the summer of 2015. So big 10-year anniversary for us coming up. And I will stop sharing my slides and I'll let the organizers tell us how we're going to handle Q&A.
Thank you, Paul. Thank you. That was really great. It's really great to see all of that and really great to review what has been accomplished. So I'm going to ask people to perhaps raise hand for the Q&A, or you can put a message into the chat and one or the other, and they will unmute you so you can ask questions. Paul, I'll start off with a question that occurred to me. You know, you talked about that we don't do surveillance. We capture people that come to clinic. We capture people that sign on to our registry, our community registry. Would you love to see us be a surveillance, move to surveillance sometime in the future? And what will we need to do that?
So I'll answer that saying I'd love for us to do that. And I'm not sure that it is economically feasible in comparison to the places where that happens are all with socialized medicine. So, the surveillance that's done by the CDC today is done as part of what's called the ATOM network, which is an autism surveillance effort that I think is at 12 sites. And CP is a subset of that. It's done at 4 sites, and they sort of pick a representative county and they do chart review at age 8 of everyone. And, and so you're getting like kind of a single point in time surveillance. But what I think is great about surveillance is you really can see if the changes we're making with, say, early detection are changing the severity of outcome or something like that. We're going to be able to see that at a meaningful scale at a center level, but I think we're going to miss out on that. And so I'd love to see it. What I think we will approach, because it's the way we can do it economically, is that we'll get to enough centers that if we were to look at something like FIS data versus our data, I think we'll see, and I've seen this with the Hydrocephalus Clinical Research Network, that what we're seeing looks like the population. And so we'll be an approximate, but it still won't be perfect capture. We'll probably be underrepresented in some rural communities. And so we will be missing a little bit. So love to have it. Don't think we'll get there. I think we will get to something that's a good enough approximation.
Yeah, I shouldn't answer my own questions, but I just also want to add on that we've recently done some work thinking about how we can diversify the respondents to the community registry, trying to think about if there's ways we could do some direct recruitment into populations that have not been coming to the directory. The community directory is very heavy in well-educated white females who are ambulatory. So we'd love to get more people that do not fit any of those categories into the community registry, so we get more diversity, and it's a challenge. That's throughout the internet world. That population is always heavy in responding to these kind of things. But we'd really like to move out and get more. Other questions?
Been also clear. There's some other things that I could say if people don't have questions that I think might be interesting to note. Like My roots are I co-founded a clinical research network for hydrocephalus. So hydrocephalus is predominantly treated by a single discipline. It's neurosurgeons. The registry that was created to capture surgeries, not clinic visits and different things. And so that network was very focused on doing randomized control trials. And so it was focused on clinical research. That said, my co-founder, who's a neurosurgeon out of the University of Utah, which is where Brent James is, and one of the leaders in quality improvement, the first thing they decided to do was a quality improvement effort on shunts, the most common way that kids with hydrocephalus are treated. And the worst complication was an infection. And so they ended up capturing a set of 17 steps, and then they reduced it to 9 steps, and they were able to reduce shunt infections from what was seen in the literature and what was seen at the baseline in their sites from about 8% to about 5%. So like something like a 35% improvement. So it was really interesting to see a set of clinicians that were very focused on randomized control trials adopt this, and now they've done more QI, and so but they continue to do clinical research in QI. And so we started with that really strong focus on doing clinical research, but then got exposed through Amy Bales. Dr. Amy Bales is our QI director. She comes from Cincinnati Children's and been exposed to the sort of educational programs of the Anderson Center at Cincinnati Children's. And so we then started to immerse in the whole learning health network area and decided to really strengthen the muscle that is QI in the network. And those are now two very big and sort of productive efforts. But we do have that start with a bias towards research.
Paul, we have a question that's kind of going to the both of us from Greg Merritt. Greg is a leader here at Michigan Medicine in patient involvement in research. And he wants to know what marketing and incentives are we trying to use to diversify, as we talked about. How do we get to the populations that are rural, low income, low formal education? Is there a strategy to capture these folks? Before you answer, Paul, I'd say we'll take suggestions and advice on that, but it's kind of difficult. Paul, do you have a comment to that?
Well, I mean, I think the first thing, why don't you first answer, what did you do you did two things to try to diversify, and why don't you describe those, and then I'll comment on some future direction.
Yeah, so the first thing we did was we went to social media, and we directed social media toward some of the influencers that have cerebral palsy. And hopefully, we suspect that the population that tunes to these influencers are more diverse than the populations that we were getting. The other thing that we're doing is, I think, very interesting, is I was approached by a medical student who is a part of the Middle Eastern and North African community, MENA, and he has a disability advocacy organization for people from that community. And we said, why don't we try and encourage them to come to the registry, and perhaps we can do some comparisons about the MENA community with the more general community that we've already looked at, to help us try and understand how cerebral palsy works in that community. So that was another way we're hoping to diversify, and hopefully by targeting a certain community, we're hoping to also diversify, by education, diversify by functional status. So there's a couple of the strategies that we're using.
And I would say that within the social media, what you did was, so we run a annual photo contest. Ours is running now, and so we try to get a diverse set of photographs, and we worked with Dr. Hurwitz's team to provide photos that had people of color as an example, or more wheelchair users, because our bias was towards ambulatory people, to try to make it so the advertising would be more identifiable for these different communities. The other thing that we are doing that I think is a long-term thing is, in particular, Dr. Hurwitz and I and an investigator from Colorado are looking at healthcare satisfaction, and we're looking at it from the perspective of something that Dr. Hurwitz observed during COVID, which is how much of his job he could do via video. And so what we'd really like to see in the future is a model where, knowing that CP expertise is consolidated in urban centers, can we create partnerships with PCPs or PM&R docs in more rural settings and be able to have CP expertise come from a more centralized place? And we think that will give us um, you know, tentacles into more rural populations.
Yeah, I should mention for people that the adults with cerebral palsy have unique health challenges. They have higher risk of certain chronic diseases. They have higher risk of fractures. They have functional decline at a much earlier age than would be expected. And this often leads to problematic interactions with their physicians who are not that educated about adults with cerebral palsy. So we would really like to expand access to physicians, therapists, and so forth who are aware of some of these differences with cerebral palsy, and help people that way, communicate with their physicians. That's a goal, and again, we hope that will expand our reach. We had a suggestion here from Dr. Vincent, Alexander Vincent, about bringing more of our partners into this effort to diversify. She mentions the American Association of People with Disabilities. The president and CEO, Maria Town, has CP. We're familiar with that, Paul?
I was not familiar with that, and I will say this is a suggestion that's really just come to my awareness just recently. I participate in one of the National Institutes of Health's nonprofit forum, and we have a discussion going on this. And really, the concept of partnering with other community organizations is a thing that we hadn't thought of. And so we've partnered with the United Cerebral Palsy, which has lots of different um, affiliates across the country that serve a much more diverse population. And we are just now starting a set of programs to reach out to Centers for Independent Living and UCP affiliates, former UCP affiliates, to really get to the place where the boots are on the ground to work with them. But we're very early stage. But I think those are some great suggestions and something we need to do a better job on.
Yeah. Chuck Friedman?
Thank you, Paul. Thank you for this outstanding presentation. It's inspiring and informative at the same time. One of the things that really impressed me the first time I came across the work by the Anderson Center is that the engagement of the patients and, in many cases, their parents in these improvement projects created almost a self-propagating cadre of active participants in the network. And in fact, one of them ended up as a student at the University of Michigan and came to us and is working on a project with Alexandra Vincent right now. Are you seeing that in your network, in terms of the the phenomenon I just described?
So I would say we're seeing a little bit of it, but I think we did. I don't want to say it's lip service, but I think the challenge is that I took my involvement and my co-founder's involvement, two, middle class, highly educated white people, and took our involvement in the community and being like co-leaders with people as something that would replicate, as opposed to seeing, oh, we really needed to nurture this more. And we're really working on nurturing it more. And so we've been doing webinars on the opportunities, and we partnered with UCP to do a a family engagement and research course offered by CanChild. And so we're really trying to grow this. We think that what we saw from our research CP was our clinicians are really open. There's not as many of those sort of built-in biases about working with community members. But we didn't start with it, so we're trying to add it in, and we are not as good as what I've seen from the Anderson Center. I've just had the executive director of the last 5 years for Improved Care Now just joined my board, and part of my goal is to engage her in some scaling up issues with regards to the community and the number of centers and whatnot. So we see it. We've got people that have been involved from the beginning in some of the processes, and they're just very motivated. They come to our meetings. They participate in bi-weekly meetings with the investigators, but it's not all pervasive like I saw when I go to the learning net seminars at the Anderson Center. So I'm trying to learn from that and improve.
We have other questions about the.
Let me add one thing. I went to Peter Margulis to get a recommendation for our keynote speaker for this year for our annual meeting, and he recommended a woman who's the mom of a kid with cystic fibrosis, and she has then gone on to get educated in quality improvement and now leads a QI team as part of the CF Learning Health Network. So I'm hoping when she tells her story, I think it's going to help us, inspire us to do even more on that front.
I have a question from Hanan about keeping community members engaged over a long period of time. And if community members move to places out of network, can they still remain engaged virtually?
Yeah, so we are very influential. We started our QI efforts in 2020. Most people as clinicians, COVID happened and everyone was like, oh, I can't do my surgeries. I can't see people in clinic. And I was like, oh, I've got everybody on Zoom. And so we are, even though we're 10 years old, we're culturally very, very virtual. And so most of the involvement that we have with the patient community is virtual. And there's very little of us doing, everything we do is network based. So we will have people from, Kansas, Missouri, New York, and Ohio on and Phoenix, Arizona on a call. And so we're inviting parents and patients into those calls as opposed to we're doing a lot in a small group. There may be huddles where a patient family would be involved at a local site, but we're doing it all at a collective level.
There's a comment here about the idea of the influencers and bringing some influencers together. I do want to say we've actually done that. I was part of a small group that had a grant where we brought together some groups. We brought together some individuals here on Palsy, and we brought together some clinicians, and we brought together some community advocates and influencers to talk about how we, different questions, including how we diversify. So we've done that. But I just have to ask this question. Someone's asked about Jason Benetti and identifies him as the Detroit Tiger announcer. I thought Jason was in Chicago. Did he come over and join Detroit? I haven't listened to Tigers for a while, so maybe I should listen in. Do you know who Jason is, Paul?
I do know who Jason is. I would say that one of the things that can be challenging, sounds like he is in Detroit, so maybe you can work on him, is that, we have all these different CP organizations, and they all work together for CP research as part of the CP research network, but they also kind of put their arms around different people. And one of the organizations is particularly good with people that are more well known. And so Jason has been in their camp. And so I try not to recruit their people, even though those people are independent and whatnot. So yeah, that would be great to get Jason involved.
Okay. Alexandra Vincent, would you mind, can we unmute you to have you ask your question? Because I'm not familiar with some of the abbreviations here.
Sure.
Yeah, please.
Yeah, thank you. I was just really interested to hear you talking about reaching rural populations. I know that some learning health networks have used this Project Echo model with the hub and the spokes model for increasing the um, skills of specialty care within general medicine populations as a way to reach, as a kind of rural medicine extension model. And then there's also PR Coin, which is another learning health network for juvenile arthritis. And I remember at the beginning of the pandemic, they had some really innovative physical exams that they were doing via telemedicine, where they were having the kids kind of walk on their heels on the camera and do other sorts of typical physical exam things, but they had managed to adapt it pretty seamlessly to telemedicine. And I think they might even have a publication on that. So just kudos on reaching rural populations. Those were just a couple of thoughts that came to mind. No real question there.
That's great. And I will say that, like, S.E. Morgan, who runs PR Coin, is part of a group of us that Kristen Howe, who was stepping down as the ED of Improved Care Now. We have a group that's called Learning Health Network Masterminds, and it's a bunch of people that have been influenced by the Anderson Center. We come together every month and we just share, like, someone will choose a topic and say, hey, can you help me with this? Or how are you doing this? And so I think it's a bit like this group, just at a very small scale, and we kind of share these things. So that's great. I'll reach out to Essie and try to learn more about that, because it's a project that Dr. Hurwitz and I we were going for it. And then we were like, we should make sure that, like, it's not build it and they will come. We should really make sure that the CP, the community, are they satisfied with their existing healthcare? Are they aware of what they're missing? And so we have a study right now running to sort of assess that. And then if that points at what we envision as being important, we hope to be able to build something like those projects. So it's great to have those names and know there are papers about them.
Okay, everybody else? If no one else, Paul, I'm going to ask you one last question, and it's just popped into my mind. On this, in this audience, we have some very top implementation scientists. And what are some thoughts about implementation science and the network? I don't know offhand if we've had an implementation scientist really working with us to see how that the network could help in some of get things moving along into the clinics. Thoughts on that?
Well, so I will say this is where I do layperson cheating. So I basically use QI as implementation science. And I know that that's not really fair, but part of being able to build measurement of outcomes or assessments into the registry really will allow us to see the implementation of different QI initiatives and whether or not they're sustaining. So, for example, in the hip surveillance, there's this key data point that people get, which is the Reimer migration percentage of the hip. And if that hits 30%, that should trigger a referral. And then the end result is, if that's not happening, there are more salvage surgeries. And so we're going to be able to see a baseline of the number of salvage surgeries based on the way we collect data. And then we're going to do this improvement and push things into care. And then we will be able to see whether or not Reimer migration percentages are being captured and are they triggering referrals and whatnot. So we have so much data about this that I do believe we will be able to do implementation, but we don't have anything currently going on that's true implementation science. It does get raised as an issue. I think we are taking some examples from, say, the CP Foundation, which has done some implementation science in its early detection work, and they're spreading some of that to us. So we'll learn more, but I would love to see us do more. And we look at this area in particular. Dr. Bales looks at the area of QI and implementation and sort of what are the sort of overlapping aspects. So that's my poor man's implementation science.
Great. Thank you. To Paul, I cannot thank you enough. Nora, could you put up the last slides, please? Paul, this has really been a wonderful presentation, and I think you've educated all of us about how a national learning health system can work and really bring value to the people that it serves. So just some next events. We have the Michigan Medicine Collaborative Quality Initiative panel is coming up in person on March 10th. There's 3 of our presenters there. We're working on getting another presenter. And we'll be talking about the collaborative quality initiatives in Michigan. Next. Okay, thank you very much. Post-event survey, please give us your feedback. Thanks, everybody.
Thanks a ton, Dr. Hurwitz. Thanks a ton, everyone, for your time. Greatly appreciate it. Feel free to send me email if you have questions, paul@cprn.org. Glad to answer any additional questions that people didn't get answered.
Okay, thanks, Paul.
Thank you.